Hello there everyone, this is Karman Bhopal and I'm back again with another part of the interview, ST3 interview stations. This is the skills stations and I would try to cover as much as possible and give you whatever I've learned whilst I was trying to gain a national training number. So starting off with the suprapubic catheter skills station, have a look at my acute urinary retention emergency station, and most of the questions are the same, so I won't repeat those answers because I've already done them. So the question is, there's a 55-year-old gentleman in A&E with acute retention, and the A&E and CT2 have failed to catheterize him, and the bladder scan shows 999 mils with significant pain. Perform a suprapubic catheter. Anyway, so we will come to how that you will perform a suprapubic catheter, but before that, how you will manage the patient, I've already talked about in the emergency scenario. What history will you take? I've talked about what steps will you take. So 16 French catheter, two-way, then couded tip, the catheter introducer, flexible cystoscopy, guide wire, and then suprapubic after discussing with your consultant. All right, so indications of suprapubic catheter is another question. So indications can be emergency and elective reasons. So emergency can be urinary retention, failed catheterization, urethral trauma, can be used for diversion surgery such as in phonias, post-bladder injury repair. Then you've got elective causes such as neurological disease, intractable urinary incontinence, poor mobility, etc. We've got a lot of indications for suprapubic catheter insertion. What are the contraindications? Okay, so contraindications include some important things and some considerations. So important ones which you can't miss is abdominal wall sepsis, vascular grafts, lower abdominal scars and adhesions, radiotherapy, non-palpable bladder, pregnancy. And then other considerations include blood thinners, visible hematuria, and bladder cancer, pelvic fractures. So all of these you can say in contraindications. Then how will you consent for it? I would let you consent for it yourself. Very important, don't miss saying bowel injury and death, because we always say general anesthetic risk, DVT, PE, chest and this, that, but in suprapubic catheter always mention bowel injury and death, and the risk of that is about 1%, so about for death. So you have to mention it because usually done in older people, especially the elective causes, multiple sclerosis, bedbound patients, poor mobility, and sometimes have previous surgery, so they can have a bowel injury and that can cause death. So 1% risk, always mention that, has happened before. Equipment needed. Okay, so that's good. So equipment, they would ask, so you need a Seldinger SPC set, which includes a needle and a syringe, a guide wire, blade, trocar, and a 16 French two-way catheter, and 10 mils for water for the balloon. Then you also need sterile gloves, Instilla gel, 10 mils of 1% lidocaine, skin preparation, catheter bag, gauze and upside dressing, and an ultrasound and ideally a radiographer. And how will you now insert the SPC catheter? So quite straightforward, check consent, contraindications and allergies. Then do a bedside ultrasound to look for any intervening bowel. Ideally a radiographer should do that unless you have the skills yourself, but you need an assistant. So over here you can say on-call consultant as well for help. Prepare and clean the area and drape. Bladder palpation 2 centimeter above the pubic symphysis or 2 finger breadths. Local anesthetic using long needle and syringe initially over the skin and down to the bladder, aspirating as we go perpendicularly. And then once there is urine in the syringe, we detach the needle from the syringe and put a guide wire through it, then use the 11 blade to extend besides the guide wire. Then we put the trocar over the guide wire inside the bladder. Then we remove the inner sheath and the guide wire out and stop the urine spraying out with our thumb and put a little bit of Instilla gel on the tip of the catheter and push it through the outer sheath inside the bladder and fill the balloon port with 10 mils of water, and then the outer sheath peels off itself. And then we attach it to the catheter bag, put dressing on the catheter site, and then we document the residual volume of the urine and the color, complete a catheter pathway and the amount of water in the balloon, previous catheter attempts and difficulties encountered, and post-procedure instructions. Also, we will send an MSU, so they sometimes say, what will you do post-procedure? So post-procedure, send an MSU for microscopy and culture, and use an ease, monitor patient for 2 hours for decompression, hematuria or diuresis. If well, no sepsis, AKI, we can send him home with safety netting, with first change with urology specialist nurses in 6 weeks, followed by district nurses changes every 12 weeks, and then outpatient urology for long-term catheter plan. Obviously, if the long-term catheter plan is made, then you do the district nurses. So unless you've made a decision that this will be for long-term. Right, so the patient's got no palpable bladder, is obese, and had previous bowel surgery. On ultrasound, the radiologist says bowel is present over the bladder. What will you do? So you'll call your consultant and consider an open cystostomy and SVC insertion. Okay, so the patient is in significant pain and the equipment is taking a while, and this is a separate case where the bowel is not in the way. So what will you do? So you can aspirate with aspirate the bladder with a 23 gauge needle if the patient was in extremis. So this is the end of your first suprapubic catheter insertion station. I just realized, the contraindications, pregnancy is also contraindication, so just add that to that question, the multiple things that I said as contraindications of suprapubic catheter, if I didn't mention pregnancy. We will discuss circumcision next in my next video, so see you next time.